Hello, everyone, and welcome to today's webinar, Trauma Verification's December Q&A web conference. You have two audio options for joining the webinar. Phone call will be better audio quality. To use phone, select phone call from the audio pane of your control panel and the phone numbers will be displayed, or select mic and speakers and the audio will come out of your computer speakers. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you, everyone, for joining today's web conference. During today's presentation, Megan Hudgens will be joining me in presenting her portion of the slides. So a couple of housekeeping things that I need to read. To qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim your CE. If you have any questions, please email the cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of all the criteria to provide quality care to the injured patient, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patients at your trauma center. So we're going to go ahead and get started. Again, for those who are new to our webinar, please be sure that you to download a copy of the PDF manual. There is a hard copy available for purchase on the e-store. In conjunction with the book, you must also use the clarification document and the change log. Any updates that we make to criteria will be printed in the change log, and any clarifications to standards will be in the clarification document. The manual is not reprinted based on any criteria changes since it was released in 2014. These are some resources for folks who are new or are just looking for information. Our recordings, our stakeholder public comment website for the revision process is still available and still open. There's a couple of tutorials for folks who are undergoing their first site visit or their first, or just wanting to understand our processes. And Participant Hub, it's available as well. Remember, you need a login to access that information, and you can update your contact information on there. And, if there's been a change in your personnel or anything like that, you can go ahead and log in and update that information. So that way we have, or I should say Megan has me update information. So when she sends her final letters and reports, we have that information. And again, I just want to let everyone know we've expanded our FAQ. There's about a little over 100 frequently asked questions on the document. We are going to update that quarterly for the time being based on any updates or any criteria changes or anything that we feel that is important to let everyone know. All questions are pulled directly from the questions submitted. There have been no edits made to the content. If your question is not answered today, the question may require more information and will receive a response from ACS staff within 1 week after the webinar. I do want to let some folks know that if you're submitting a question through the web portal, to please be sure to submit the question in full sentences and clear. Sometimes it's a little difficult to understand the question, and sometimes I call myself the master in ciphering, but other times it's a little challenging to know what the intent is, and sometimes it does require more follow-up. So again, just a reminder to submit your questions in clear and concise sentences. Scheduling reminders and updates, as previously mentioned, we're going to do these every other month. That way it's not repetitive. So the next presentation on scheduling site visits and what's available for scheduling in 2019 will be presented during January 2019. I will say that if anyone on the call is really needing to submit an application or is concerned about submitting an application late and not getting your time scheduled or if it is scheduled, to go ahead and email the cotvrc@facs and we will answer that or forward that to Rachel who can let you know what's the next available time slot. Just a few announcements, or actually one announcement. The next verification Q&A webinar is scheduled for Monday, January 28th. And that's at noon Central Standard Time. So you have the deadline to submit questions on Monday, January 14th. So we're going to go ahead and start with the general questions, and this is where I'm going to transition it to Megan Hudgens.
We don't really dictate one way or another what your center chooses to do. It's really up to you. So we have no stance about what the pre-hospital report is called. If it's moving at your center, then that's fine. If it's missed, that's fine. Whatever works for you. So here's one on advanced practice providers. Do L2 adult trauma providers who once in a while see PEDS trauma always with the PEDS ERMD, must they have PALS or is it optional? So, excuse me. APPs who see pediatric trauma patients with the ER attending during the consult tier or non-activation phase are not actually required to have ATLS or PALS. And a good note to throw in here is that we don't really have any specific criteria about PALS. So for ATLS, the big thing to keep in mind is that for APPs who do participate in the initial evaluation and resuscitation efforts of the patient, if they're not just involved like in a scribe capacity or something similar, they would be required to have current ATLS status in order to maintain compliance with CD 1186 as noted here on the slide. So here's one on admitting policies. Should all elderly patients with isolated injuries or brain bleeds post-fall from a standing position be admitted to trauma? This is another one of those ones like we discussed with the pre-hospital report. This is kind of up to your center and what the specific needs of your center are. Best practices though, we would say admitting to the trauma service with a neurosurgery consult for the first 24 hours would be the ideal practice. And one on admitting fractures. Does the ACS address anything about which specialties should be consulted, ortho or trauma, for fractures admitted to medical? So again, the admitting policy in this case would be determined by the trauma center, what your specific needs are, what works best for you. For best practices though, the patients who meet trauma inclusion criteria should be admitted to the trauma service for 24 hours to rule out just any other injuries, avoiding readmission in the future, and giving them an orthopedic surgery consult. So with that said, it would also be acceptable to admit to the orthopedic service with a trauma consult. And here's a question on response at bedside. Who are the required personnel whose bedside arrival times need to be recorded, i.e. respiratory therapy, x-ray, CT, anesthesia, etc. And this is for level 3, which is definitely relevant to which ones we want to be included. So for verification, the following are required to be at bedside. These include but are not limited to the trauma surgeon, the emergency physician, neurosurgeon if you have neurosurgery capabilities present, the orthopedic surgeon, anesthesiologist or CRNA, the full range of trauma nurses, ED, PICU, PACU, radiologists, CT tech, respiratory therapists, physical therapists, social workers, and the registrar, if your volume is greater than 750 or if the TPM is encumbered. And here's one on backup call schedules. Are level 1 centers required to have a backup schedule for ortho spine and or neurosurgery covering spine call? We did talk a little bit about this one in the office the other day, just to kind of see if we understand really what the question is asking. So if the question is asking, must there be a separate backup call schedule for spine? Then no, that's not something that we require. For level 1 or 2 trauma centers, spine call may be shared between the neurosurgery and orthopedic surgery group. So if one of these groups is covering spine call, then the orthopedic call system, backup call system, or contingency plan for the other may be triggered as noted below in the requirement for level 1 and 2 trauma centers, having a neurosurgery contingency or backup schedule, and orthopedic having dedicated call or backup system. Another one for backup call schedules. We are pursuing a level 3. Do we need a backup call schedule for trauma surgeons? And so, no, a level 3 trauma center is not required to have a backup call schedule for trauma surgeons. And here's one for EMS Transport Information. Is it mandatory to provide EMS agencies a follow-up letter on every patient they transport to your center? This is from a level 2. So no, this isn't required. It's definitely a good idea to share any information or any best practices that may have resulted from something positive or negative that occurred in the pre-hospital phase. So, you know, keeping them informed and keeping them involved in the process is certainly important, but we don't require a specific follow-up letter to be sent to the EMS agency for every patient that's transported. And here's one on focused review. With a focused review at a level 2, if all prior deficiencies and recommendations were appropriately addressed, but there is a deficiency identified, will there be a second focused review or is verification retracted? So, well, during a focused review, I mean, as the name suggests, the review team is there to evaluate the previously cited deficiencies. However, if there is another deficiency that is identified during the focused review process, something like blatantly sticks out, then that would be cited, and there is never a second focused review, so verification would not be extended to the full 3 years.
So I just want to interject here. For the person asking this question, if you have any more questions, you can call me directly. But I did want to add that the intent of a focus review is not to go looking for additional deficiencies. The intent of a focus review is really, whether it's on-site or by mail, where the reviewers are strictly looking at those deficiencies that were cited. And as Megan said, that if they're looking at those deficiencies or the corrective actions that you put together for those requirements, and there is a deficiency within reviewing that information, then it is very possible for the reviewers to cite another deficiency. It happens very rarely. I think it's only happened once in my lifetime here. So if the person who submitted this question has any concerns about this, please contact me directly and we'll go over that. Thank you.
All right, thank you, Molly. Okay, we have a question on M&M review. Is trauma M&M an adequate tertiary review of a trauma case that falls out due to audit filters? So I just want to point out, so that we're using the same terminology and that we're all on the same page. There are many trauma centers use many different titles for their peer review meetings. Fine. If in this case, for this question, the trauma M&M meeting noted here is a separate meeting from the peer review meeting, then this probably would not be the ideal place to discuss or review trauma cases that fall out due to audit filters. These would include trauma activations, emergency department length of stay, over and under triage, washout times for open fractures, and so forth. So the peer review meetings would probably be the ideal place to have those discussions. All right, one for OPPE for advanced practice providers. Can the OPPE for trauma/SICU APPs be completed by our SICU director/trauma surgeon with TMD oversight, or does the TMD have to do the OPPE independently? So sort of like how we do for neurosurgeons and ortho, the SICU director can complete the OPPE for advanced practice providers under their supervision. We just ask that in order to maintain compliance with criteria, the TMD should be involved, should have some oversight. There should be some sign-off process so that the reviewers are aware during the site visit that the TMD is aware of the process and has involvement. And here's one for over triage and under triage. Does a center have to use the Kribari method to assess over and under triage at their facility? This is from a level 3. So no, this isn't something that we require. It's sort of one way to get to the objective. It's very common. We see it in a lot of reports, but it's one method to evaluate your under and over triage rates. So it's definitely an option that you can use. And another for over and under triage. We meet with 2 of our largest transport agencies each month and review patients for over and under triage, etc. Is that adequate? So yeah, that is a good idea. The big thing to keep in mind is that you do still want to have a mechanism available to track and evaluate the over and under triage rate, just to ensure that the center is in compliance with standard 3.3. And we have an example actually on the next slide for the ISS method. So yeah, we would want to have like a firm percentage, specific numbers. You would isolate and analyze transfers in separately and just use those results to update and educate on your activation criteria. And sorry if you hear any banging in the background, we do have a bit of construction going on. But so here's one on the peer review meeting. In trauma peer review, can only the TMD or associate TMD sign off on chart review? So medical records presented at the peer review meeting should be signed off by the TMD and or the associate TMD. It mostly demonstrates to us that his or her responsibility for the case review. And here's an interesting one on the discoverability of peer review minutes. Definitely a very important issue. Our corporate risk/compliance division has reached to many of our subsidiaries regarding the amount of detail we are putting into our peer review minutes and concerns from a legal standpoint. So for verification purposes, you definitely don't want a transcript of the medical record. It should be a case summary. And I would advise checking out the HIPAA guidelines for more specifics on what specific data filters you're going to want to exclude. Patients age over 89 is a big one because the patients 90 and over is a smaller subset and a little bit easier to search. A few other ones that come off the top of my head, geographic subdivision, smaller than a state. You can obviously talk about your own region, your hospital, etc. But let's see, we do occasionally come across medical record numbers, social security numbers. Definitely don't include those. And that's a good rule of thumb for really anything that you send to us as well. We do occasionally receive corrective action documentation that has to have those values censored. So just something to keep in mind.
I was going to say, Megan, if you can talk a little bit about the report and what you see in the report, you and Bhumi. I know you covered a little bit here, but if there's anything additional that you want to add to this, you're more than welcome to do so.
Okay, yeah. So this is something that we do keep an eye out for in the reports, and we do educate our reviewers.
Medical records.
Oh, medical records, yes, the charts. As you might know, if you've received reports from us in the past, we do have a case review section that has a list of the case summaries. We do educate our reviewers on these same issues and what to include and not include. Specific dates and times is another one. That's a big one, I think, because it's very tempting to include like date of admission, times of certain procedures so that you can track, say, when a trauma surgeon arrived and so forth. The big thing that we suggest doing is using elapsed times, like the trauma surgeon arrives like 10 minutes after patient arrival or something to that effect. So a clause will be added to the review agenda that will read, peer review minutes are not discoverable. Please be advised, though, that most states have a protected peer review process. So if you have any questions, please don't hesitate to ask. Definitely better safe than sorry. And here's one for chapter revisions, TEG. Any updates on the use of TEG? Will it, so thromboelastography, will it convert from should to or must have? And as you know, this is one of the kind of verbiage things that we use, should being an ideal and must being related to a deficiency. At this time, we don't really have an update regarding TEG. This chapter is still under review. So as you all might imagine, given, well, we've all read the Orange Book and we know it's a very dense, it's a very dense text. The revision process is certainly a beast, and we will update you as soon as we have more information on any changes. And Here's one on anesthesia. Is there a waiver that can be submitted for the requirement of in-house anesthesia for level 2 trauma centers? Presently, we do not have a waiver for anesthesia at rural level 2 trauma centers. If we make any changes to that, we will certainly let you know. But at present, we do not have this in practice. So here is a question for non-surgical admissions. Please explain the intent of capturing non-surgical admit data. Shouldn't it measure how patients were not seen by trauma or surgical specialties, either by consult or eval, instead of counting how many were admitted to a non-surgical service? Seems as though the group we're trying to capture here are injured patients without trauma/surgical specialty involvement. So ideally, yes, this would be how this criteria would be written for the next edition of the resources manual. So this is something else that we have on the agenda. However, the current criteria, as we have written and finalized and are evaluating centers under, is asking for the number of patients who are admitted to a non-surgical service being reviewed for appropriateness of care. And another one for non-surgical. Has the ACS redefined what non-surgical admission means? We have always taken it to mean any injured patient admitted to medicine. So non-surgical patients, or non-surgical admissions, are patients who meet the NTDS or your trauma center's inclusion criteria and are admitted to a non-surgical service. And these can include, but are not limited to, medicine, geriatrics, neurology, neurocritical care, pediatrician, or intensivist, such as pulmonary, anesthesia, or medicine. Just so we have that term defined. And here's one for neurosurgery capabilities. If a level 3 program has 10 days of neurosurgery emergency call, would you consider that a level 3 with or without neuro? Yes, this would be something that we would consider level 3 with neurosurgery capabilities. So when you fill out your PRQ, you would want to indicate that you do provide neuro care and answer the relevant sections, the relevant questions in Chapter 8. So, and these would need to be in compliance at the time of the site visit. Here's one for registrar continuing education. Are trauma registrars still required to have trauma-related continuing education credits? If so, how many per year? So presently, we don't have a requirement for registrars to have continuing education. There are some criteria that we're going to discuss in the next slide, but as noted on page 111 of the resources manual, it reads as follows: registrars should complete a minimum of 8 hours of registry-specific continuing education per year. So this is the best practice, but it's not something that we're going to cite a deficiency for. Another one for registrars, share how the registrar level, there are many projects that can be shared. They don't have to be a nurse. Okay, so if I'm interpreting this correctly, so there is no requirement that the registrar must be a nurse. It's often the case, but it's not a requirement. The registrar should receive initial training, but is required to attend 2 courses within 12 months of being hired. These include the ATS registrar course or equivalent, and number 2, the AAAM injury scaling course. No equivalent there, it has to be that course to be in compliance with CD 15.7. So hires after July 1st, 2014 must have attended or previously attended a trauma course, a training course at the time of the site visit. New registrars must have that training within 1 year, and those hired prior to July 1st, 2014 would be grandfathered in this criteria, so would meet it automatically. And here's a question regarding DIEDs and DOAs. Can you provide some guidance on DIE versus DOA? Any procedure/intervention in the ED makes it DIE, i.e. EPI admin, bedside x-ray, or fast. So the VRC does not define death in the emergency department or DOA. This is one of those things where the terms will vary from center to center, and defining them will really be up to you or your state regulations. So we don't have a firm stance on that one. This one for geriatric patients. I am interested in information surrounding geriatric/trauma and what specifics will be reviewed or required for ACS verification. So trauma centers aren't actually required to have a geriatric service. We do have some questions about it in the PRQ. It is ideal to have one if your trauma center sees a high volume of these patients. The expectation for these programs is to have a process or guideline in place to manage those patients. If you have developed guidelines for geriatric patients, just have that information readily available at the time of the site visit. So no, there's not a deficiency that you would be cited, but it is something that, you know, potentially could be like an opportunity for improvement with a recommendation. Here's one for locums. Are per diem surgeons who live in other states required to attend 50% of PIPS meetings? Yes, we do get this one quite a bit. For all trauma centers, locums who are treating trauma patients must meet the credentialing process and same requirements of the other surgeons, such as this is a board certification, this is OPPE, and of course this is attendance at the peer review meeting at no less than 50%. So as a reminder, the peer review meeting can be attended in person, by teleconference or video, whichever is most convenient for your staff. So just something to keep in mind. And here's one regarding the PRQ for washouts. So does an IND in the OR for open fractures count as a washout as referred to in the PRQ for average time to washout? So an IND in the operating room would count towards the average time to washout, so you would include that in that figure. An IND in the emergency department, however, would not count, so you would not include that. So here's one. We are due to be re-verified in spring of 2020. If the updated resources for optimal care book is due out at the same time, which standards will we be evaluated under for the verification review? So those of you who underwent a visit in like the year or so immediately following the release of the Orange Book may remember this. We do have a grace period of 12 months starting from the date the new resources manual is released, just to give you the opportunity to implement any new or edited standards. We don't want to set you up for failure. We want to give you as much time, we want to give you a reasonable amount of time to implement any of the changes that we are putting forward. The ACS requests specific parts of the EMR to be printed and have on hand at the time of the site visit. Can the ACS tell us in advance which charts they will be reviewing to eliminate the need for unnecessary printing and expense to do so? And we do understand this. We want to save trees and your wallets. So the review agenda has a list of medical records by category and the minimum number required at the time of the site visit. We do have a link here in the slide for you to take a look at. Unfortunately, we cannot tell a trauma center which medical records will be reviewed. A big part of this process is the random selection element for the charts. That said, we have an ongoing medical record pilot that will end this year, which decreases the number of medical records needed during a visit. The data from these visits will be presented, the data from these visits will be presented to the VRC and Executive Committee for approval during the 2019 COT annual meeting in March. And then more information will be provided thereafter. You will be the first to know.
So I want to interject a little bit here. So I know a couple of folks had approached me during the TQIP conference about this pilot. Because it was a very short window, we had to start this pilot and ask trauma centers to participate. We have met that quota, so those trauma centers that are participating, actually we're going to end this in 2 weeks. In 2 weeks it'll come to an end, it'll come to a close, and then we're going to gather whatever data from the 12 to 15 trauma centers that participated in this pilot process. And again, as Megan said here, we're going to present that information to the committee during our March meeting, and hopefully that will be approved and provide an option, whether trauma centers want to do the short version versus the current standard. So we're hoping that this does get approved, and it would be a huge benefit to trauma centers, as you know. And so more information will be forthcoming after that March meeting.
All right, thank you, Molly. Okay, so rural EMS departments often do not send us reports. Patient goes to a fixed wing medevac and no report. Will we get a deficiency? Oh no, so the trauma center will not be cited a deficiency if there was no EMS report. So the important thing here is that you want to ensure there was an effort made to obtain a copy of the EMS report. These efforts, along with a note that the report was not received, should be documented in the medical record available at the time of the site visit. So if we have an EMR, can the items requested for review be generated into a PDF file/folder per patient, or must we paper print? So if the trauma center has an EMR, it's not required to print the entire medical record. So the thing to keep in mind is that the EMR software must be easily tabulated to display the contents listed below. These include pre-hospital, EMS run sheet, transferring facility ED info, if that applies, trauma flow sheet, HMP, consult notes, operative report and notes, discharge summary, autopsy report if this was a mortality with an autopsy, and copies of the PIPS documentation if that is applicable. And if the EMR software is not able to display that information, then those contents must be printed for the reviewers. So during the November web conference, it was stated that an OTL form and CV must be submitted for all level 1 centers with the site visit application. I thought if it was previously submitted and had not changed, you did not need to resubmit has this changed. So to clarify, the OTL process does not actually require a copy of the CV. That's usually more of an alternate pathway situation. But if an OTL form was previously submitted and there has not been a change, you would still need to submit a new form, but similar again to the alternate pathway process, which is truncated the second time through, you would only answer questions 1, 2, and 3. And during chart selection, if there are not 10 charts in a category, is that acceptable, or should you fill the remainder with others? So if you do not have the minimum number of 10 medical records in any of the categories, just pull what you have available at the time of the site visit. You don't want to double dip. If there is a category with less than the minimum or even 0 medical records, you wouldn't fill the balance with others. If you have a multi-system injury, like I said, don't double dip. You don't want to copy the medical records, just place it in the most applicable category. So during a verification review, how do you present PI you have done that is not directly related to a particular patient chart? So if you have done PI on an audit filter or something that has positively impacted your PIPS process, you can present it to the review team during the medical record review discussion, or possibly at the review dinner. Either of those would be probably the ideal place to put that information forward. All right, and if there are open positions for neurosurgeons at the verification visit, will the center fail re-verification to a level 2? So short answer, no. Having open positions for neurosurgery is not a deficiency. I do have follow-up questions for this. If there are no neurosurgeons currently on the trauma call panel that can consult or manage trauma patients, then yes, this would be a type 1 deficiency. No verification would be granted. We would need some details of the circumstances. The most important thing that we would want to ensure is that the current volume of neurosurgeons that you have practicing on staff now is enough to meet the needs of your trauma patients. And I'm going to turn this back over to Molly with some CD-related questions. Thanks, everybody.
Thank you, Megan. So we're going to continue on with CD-related questions. So this has to do with the TMD's authority and responsibilities. How exactly is it expected that the TMD have responsibility and authority for determining each surgeon's ability? So basically for surgeons who are serving on the trauma panel, the trauma medical director has the authority and administrative support to lead that program. A lot of this is done through the credentialing office. And then the trauma medical director has the authority to manage all aspects of the trauma care. Also, he or she has the authority to include and exclude members from the trauma call panel who don't meet specific criteria, and that could be criteria outlined in the resource manual, just like board certified or attendance at the peer review meeting, things like that, or additional criteria set forth by the trauma center. And also the trauma medical director performs annual assessments of the trauma panel members, as Megan reported earlier. We're only asking the trauma medical director to be involved in the other specialty groups OPPE process and their advanced practice providers OPP process. They don't need to necessarily perform it. They just need to be involved in those decisions, especially if they're providing care to trauma patients. I have a question regarding PGY 4 and 5 residence requirements. I was not able to locate any defined requirements information on this in the clarification document nor the FAQ, but need to ensure this is being correctly interpreted. In reference to PGY 4 and 5, are there specific requirements for trauma call coverage 24/7? Is there a difference between night and day if there are specific requirements? I can only find specific requirements that may begin the resuscitation while waiting for the attending. I see there is verbiage regarding the senior residents having a continuous rotation in trauma surgery, but do not see this specifically delineated. Is this correct interpretation? So your interpretation is correct. There really is the only requirement, it's not even a requirement in the book, it's really more of a shared practice that the PGY 4 and 5 at 1s and 2 can begin the resuscitation while waiting for the attending surgeon to respond to the highest level of activation. Now, the resident's time can account for the attendings. And then in level 1, 2 pediatric trauma centers, that includes a PGY 3, 4, and 5. So that is where it speaks about the resident. The other areas, again, not a requirement that talks about the resident is if you're using residents for neurosurgery or orthopedic to provide the consultation to the attending. But again, no direct requirements on that. Direct physician contact, CD 4-1. We had a couple of questions about this. Basically, the question is, please clarify if an MD is needed or if an APP can perform the direct physician contact. Not all facilities have physicians for the inter-hospital conversation, which is correct. Can our level 2 acceptance be done by an NP? Absolutely. So an advanced practice provider or nurse practitioner is acceptable to perform this task. There are some states that I don't have this on the slide, but for those people who are on the call who are in a state where you have a call center, again, that's also acceptable, but you want to make sure you're documenting these conversations just to make sure it doesn't impact your over and under triage if you're accepting patients, or I'm sorry, disregard that. If you're accepting patients and don't have the ability to manage the care of those patients, or have room to take in those patients. So you just want to make sure you're having a conversation. This transfer CD 4-3, the statement that all transfers must be reviewed in the PIPS program, is this referring to transfers in or transfers out? This is referring to both. So you want to review all your transfers, whether that's transfers in or transfers out. Cost schedule for trauma surgery, for trauma surgeons really. Are the requirements for trauma surgeons taking backup call the same as primary call, such as 50% attendance at peer review? So the short answer of this is if you alternate your backup with your primary being on primary call, then really they're part of your trauma call panel. So that means that all trauma surgeons who are on your trauma call panel have to attend the peer review meeting 50% of the time. So again, if the backup call schedule is comprised of trauma surgeons or general surgeons, I know the word terms are interchangeable, and they alternate with the primary call schedule, they are required to meet the same requirements as board certified, OPPE, peer review attendance, etc. If an ATLS certified PA completes the initial evaluation for a modified trauma patient, does the PA's arrival time take the place of the trauma surgeon's 30-minute response time? So if I understand this question correctly, because what's really throwing me off on this question is the modified trauma patient. So I don't know if that means they came in as the highest level of activation and there was a modification to that. Again, I'll answer this as best I can, and if there's further clarification, by all means, reach out to me. For the highest level of activation for a level 1, 2 trauma center, the response time is 15 minutes for a level 1 and 2, it's 30 minutes for a level 3. The PA's response time for any of these trauma center levels cannot take the place of the attending trauma surgeon's response time. So that's totally separate. Now, If this is referring to the limited tier of activation, again, modified trauma makes me think it's maybe a limited tier of activation where the institution has defined a response time of 30 minutes for the attending trauma surgeon to arrive. Again, the PA's response time cannot take the place of the attending trauma surgeon's response time. So the attending surgeon's response time is its own and the PA is its own. So it's two different times there. Limited tier activation, other potential criteria. What would reviewers like to see the trauma center has done to meet this criteria? So this standard may impact the over and under triage rates. Reviewers want to know that you are reviewing your over and under triage rates, however you do that, whether you're using the CRIBARI matrix or your own matrix or something that you found that helps you capture that. Are you monitoring and reviewing your activation policy on an ongoing basis through your PIPS process to capture any outliers that triggers your rates? And if there's any outliers, have there been any updates based on that outcome made to your activation policy? So again, if you have anything that's impacted your activation criteria or any changes you make to your activation criteria and it's gonna impact your over and under triage, or again, just your activation, you can present that to the reviewers. And also they'll capture some of that during the medical record review process. And again, I just want to disclose that we have some ongoing construction in the building, just the floor above us, so you're going to hear some pounding and probably jackhammering in a second. Non-surgical admits, we have a recurrent scenario of ambulatory elderly patients falling, hitting their head, and has a brain bleed or other isolated injury. We are looking for an official answer on these patients being admitted to the trauma service. We understand that it brings up the question, which came first, the chicken or the egg? I know that it typically is for the physician to err on the side of caution if the brain bleed is remotely related to the fall occurring as a result of the head being struck and admitted to trauma. We are a designated Florida Department of Health Level 2 Trauma Center, not an ACS verified, and we do not have non-surgeons, medical intensivists admitting such patients as well as a trauma service. Neurosurgery is consulted in both scenarios. We understand that best practice to admit to general trauma surgeon in these cases because of the potential for identifying other injuries, rib fractures, C-spine injuries, abdominal bleeding, etc., especially in the first 24 hours. Please let me know which route I should go with this question. So, you know, as we keep mentioning, as you know, best practices would be to admit to trauma service. And again, that is going to be based on your trauma policy, if that's what it is. But basically, best practices says to admit to the trauma service for a period of time, and then the patient can be transferred to medicine, you know, with a neurosurgery consult. It would also be acceptable to admit to medicine with a trauma and neurosurgery consult. So there's no wrong answer in this. And again, it's going to be based on your hospital policy and how. ACS expectations for non-surgical admits. 1, determine the percentage of non-surgical admits. 2, review each case, ISS 9. 3, care appropriate. If ortho admits versus general surgery, this is acceptable. Those non-ortho review all records or just ISS 9. So a lot going on with this question. I hope that my response answers this person's question, because it's a little complex, I think, and I'm not really sure exactly what they're asking. But what I want to say about the non-surgical admits, you don't want to just review those with an ISS of 9. You want to follow the grid on a page 121, which kind of gives you an outline of how to review those and how to categorize those. And second part of this is patients admitted to orthopedic service are acceptable and were not necessarily, and again, depending on the injury, it would be acceptable to admit to ortho service, and that would not count as a non-surgical admission because ortho is a surgical service. If the admission was to a non-surgical service, then that patient, if the admission was to a non-surgical service, then you want to ask that that patient receive a surgical consult, and if not, you'll want to review that through your PIPS process to determine if it was appropriate. I know this question came up a couple of times last month, and then we're just gonna, someone again submitted the same question. We just want to make sure that we are clarifying the intent for a level 3 trauma center. And I know Megan earlier in the presentation had a question about the what personnel are needed at a level 3, and we talked about the trauma program manager. Can also be the registrar. Again, it could be the same person, or depending on the volume, or depending on if it encumbers their workload. So our level 3 trauma centers required to have a trauma program manager. If they don't, is it a deficiency? I work at a level 3 trauma center. My question is, do we have to have a full-time trauma manager? So for verification purposes, the titles of trauma program manager, coordinator, trauma director, not medical director, but trauma director, are all interchangeable for us. So they all mean the same for us. So a level 3 trauma center is required to have a trauma program manager or coordinator, but is not required to be full-time. Again, as Megan said earlier, at a level 3 trauma center, that the function of the trauma program manager can be shared with the registrar role, as long as it doesn't encumber their day-to-day workload. If the trauma program does not have a trauma program manager or coordinator, it will be cited as a deficiency. Chair of trauma peer review meeting. Who can chair trauma peer review in the TMD or associate trauma medical director's absence? So while there's an alternate or a predetermined alternate designee for the liaisons, unfortunately, there is not one for the trauma medical director or associate director. They are responsible to chair the peer review. So the trauma medical director or associate trauma medical director must chair the trauma peer review meeting. There is no alternate representative that will satisfy this criteria. Can the resident, fellow, or attending be the responding physician for the 30-minute neurosurgery response similar to ortho? Short answer is yes. The neurosurgery resident or fellow or attending or PA or APP may be the responder for the 30-minute response based on conditions defined by the trauma program. However, if that is the case, there must be clear documentation with the attending neurosurgeon on the plan of care for that trauma patient. Chapter 8, VRC standard frequently asked questions states that in regards to copies of neurosurgery backup cost schedules, the center is required to demonstrate compliance with all standards. True. This includes documentation such as cost schedules, backup cost schedules, trauma protocols, administrative commitment letters, etc. CD83 states that trauma center must provide a reliable published neurotrauma cost schedule with formally arranged contingency plans in case the capability of the neurosurgeon hospital system to care for neurotrauma patients is overwhelmed. A published neurosurgeon backup cost schedule is the best method to meet this requirement. However, because of the significant shortage of neurosurgeons in many hospitals and regions of the country, other creative methods to ensure timely and appropriate care may be used. Could you please clarify whether or not a neurosurgery backup cost schedule is required if a contingency plan is in place? If there is a contingency plan in place and no formal backup cost schedule, how do we answer question number 8 in the neurosurgery section of the PRQ without automatically creating a criterion deficiency? Now, I think this was a great question only because early on we did have some complications with these two particular deficiencies and how they were programmed in the PRQ. So if you answer no to one and yes to the other, it triggered a deficiency. I'm here to report that we have fixed that. That no longer is an issue, so it is programmed correctly. So if you answer yes to question 8 and no to question 10, again, you're not going to be cited a deficiency. It's not going to trigger a deficiency. And furthermore, when Megan and Bhumi receive the reports, we do an audit of the report and look for things like this. before they are released to the committee for review. So to answer the question, a neurosurgery backup call schedule is not required if there is a contingency plan available and vice versa. So again, the PRQ regarding these questions have been programmed to not trigger deficiency if question 8 is answered no or yes, and the same is true if you answer question 10 with a yes or no. Is it acceptable to have a liaison from neurosurgery who is board eligible but not yet board certified? Yes, it is. That is acceptable. So a neurosurgeon who is current in their board certification or eligible is acceptable to be the liaison. I know it doesn't say that in the book, but it is acceptable. Please clarify the following CD 2-6 in a level 1 trauma center. The orthopedic care must be overseen by an individual who has completed a fellowship in orthopedic traumatology approved by the Orthopedic Trauma Association. Does the overseen by imply a position of medical directorship, or does this simply mean that a provider who has completed an approved fellowship cares for and generally directs the clinical care of trauma patients with orthopedic injuries? So the intent of the OTL criteria is that there is a provider who has completed an OTA fellowship on the trauma call panel, and that person can or should direct the clinical care of the trauma patient with orthopedic injuries. Again, it's a should. It doesn't mean that they have to be your liaison in most trauma centers. Again, this is from a level 2. I do want to clarify that if you're a level 1 trauma center, most often, but it's not all the time, the OTL or the OTL who is fellowship trained generally is the liaison, but it does not need to be the liaison. We're just, again, the intent is that there is someone on the trauma panel that has completed an OTA fellowship. If the adult trauma surgeon provide backup call coverage on certain days but do not participate in primary call, do the adult surgeons need to participate in pediatric trauma peer review meetings? Our pediatric surgeons cover all primary call and meet the requirements mandated for those that cover trauma call. The adult surgeons only provide backup when needed. So all of the adult trauma surgeons are not required to participate in the pediatric review meeting. The peer review meeting for programs that are combined, or in this scenario, should have or must have or may have a representative attend either the adults peer review meeting or the pediatrics peer review meeting, and any information resulting from those peer review meetings should be disseminated to the other members of the group. So again, if you're in a combined trauma center that has separate peer review meetings, if you have one predetermined or a representative from the adult service attend the peds, that person can come back and relay or disseminate whatever information was discussed during that meeting. And the same is true for pediatric surgeons. Is the trauma surgeon required to be primary attending on all trauma ICU admissions throughout their ICU length of stay? So CD 1158 and 59 speak to this. The admitting trauma surgeon is responsible for the patient and coordinate all therapeutic decisions while the patient's in the ICU. Now, the dedicated ICU team may collaboratively manage the daily care of those patients, but daily care requirements with the admitting trauma surgeon being kept informed and concur with major therapeutic and management decisions. So the dedicated ICU team is going to provide coverage as long as they let the trauma surgeon, the admitting trauma surgeon, know of any major therapeutic and management decisions that are being made. What does the college deem is an adequate supply of packed red blood cells and FFP? The VRC does not define adequate supply of packed red blood cells and FFP. The intent is that the trauma center has blood products available to meet the needs of the injured patient. Again, we don't define that. For a level 3 trauma center, what is the requirement for injury prevention education? So the standard is that all trauma centers must have an organized and effective approach to injury prevention prioritized based on local trauma registry and epidemiologic data. So in response to this person of what the requirement is, that's what it is. So with that being said, there may already be programs established in your community that you can join and participate in. There's a couple examples of some, like Stop the Bleed is major this time, or recently, actually, in the recent year. So for level 3, that is the requirement, and you can actually join or participate the Stop the Bleed or Think First or Safe Kids or any other injury prevention education programs within your region. Universal screening for alcohol. How does ACS identify trauma patients needing the CAGE assessment? Is it by ETOH and the ED or suspected problem? The requirement really is that all trauma patients alive and participatory, regardless of activated or non-activated, who meet inclusion criteria with a hospital stay of greater than 24 hours, who are admitted to the hospital and entered into the registry, are screened, and only 80% of those that are screened, we're asking for 80% of those to be screened. So it's not based on whether you suspect a problem or the ETOH. It's really just doing a universal screening for all of the patients that meet that requirement. Now the screening method, whether that's CAGE or ETOH, will be determined by the trauma center. Just one question about CME. So do liaisons to the trauma committee still need external verify CME with the new change? Liaisons who are current in their specialty MLC are not required to have CMEs. So this concludes our webinar for today. Thank you for participating and happy holidays.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's December Q&A web conference. If you have any other questions, please contact cotvrc@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today and have a great rest of your week.